sound cheering. So welcome.
Welcome. Good afternoon, everyone. My name is Alexis Adams, and this is Amanda Malik. And on behalf of the School of Public Health Student Government Organization, welcome to Drexel University School of Public Health Grand Rounds. The School of Public Health is honored to have Dr. Don Schwarz, Health Commissioner and Deputy Mayor for Health and Opportunity for the City of Philadelphia. Dr. Donald Schwarz is the Health Commissioner and Deputy Mayor for Health and Opportunity for the City of Philadelphia. Dr. Schwarz completed his medical education and received a Master's of Public Health at Johns Hopkins University. He then went on to pediatric residency at Yale New Haven Hospital and came to University of Pennsylvania as a Robert Wood Johnson Clinical Scholar. He received a Master's of Business Administration from the Wharton School and went on to finish a one-year fellowship at the Children's Hospital of Philadelphia. Before entering government service, he was Vice Chairman of the Department of Pediatrics of the University of Pennsylvania School of Medicine, Deputy Physician-in-Chief, and Craig Delsimer, Division Chief for Adolescent Medicine at the Children's Hospital of Philadelphia. He was Professor of Pediatrics in the University of Pennsylvania School of Medicine and Nursing and a Senior Fellow at the Leonard Davis Institute for Health Economics at Penn.
Dr. Schwarz was an active researcher in the area of adolescent risk behaviors for over 22 years. He received both public and private funding for work that examined the issues of injury and its prevention in urban minority communities, public policy approaches to adolescent violence, and physician and nurse-based practice interventions to improve outcomes for high-risk infants. In his current role, Dr. Schwarz oversees the Philadelphia Department of Public Health, as well as the Department of Human Services, Department of Behavioral Health and Mental Retardation Services, and the Office of Supportive Housing. Before the presentation, the Grand Rounds Planning Committee would like to announce that neither they nor Dr. Schwarz have any commercial relationships to disclose. They would also like to remind you to please silence your cell phone. Please join us in a round of applause as we welcome Dr. Don Schwarz.
Thank you, Amanda and Alexis. And I am delighted to be here. I always like coming over. Hopefully everyone knows that the Department of Public Health is only a very short distance away from here, and everyone is always welcome. And let me use this opportunity to acknowledge two members of the faculty in particular, Dr. Shannon Marquez and Dr. Marla Gold, who are members of the Board of Health for the City of Philadelphia. I appreciate your service, your colleagueship, partnership, and leadership. So thank you. I am here because your dean heard me give a talk like this one at the College of Physicians and said, here's an opportunity to link for people what public health departments can do and how they measure what they do. And I was very honored to have Marla in particular say that. So I'm here to share with you a little bit about what we've done and been doing in the city. For those of you who have been here for a while, you've heard this develop over time. So I've been to these grand rounds over the past few years, periodically, to tell you what we're focusing on and what we're doing. The good news is we now have some outcome information, and I'd like to share it with you as we go through. So I've incorporated it into this talk. What I'm going to do is orient you a little bit to how we've been setting priorities for the Department of Public Health and some of the things that we've done about those priorities. These do not represent all of the priorities for the Department of Public Health. There will be notable things missing from this, so if anybody has a pet area of public health, I apologize if I'm not mentioning it. Doesn't mean it's not important, doesn't mean it's not a priority, but does mean it's not part of this presentation. And with that in mind, let's see if technology will work for us today since you've already seen the first slide. The way that departments of public health, I think, need to begin setting priorities is fairly complex. One of the things that public health uses, hopefully you all know, is data on death. We use data on death because it's easy to count people who have died and to sort of figure out in a standard way how they've died. Death data from the city of Philadelphia, like other parts of the United States, show that the two biggest causes of death in America for all Americans are cardiovascular disease and cancer. People have known that for a long time, and in the city, we have done variable degrees of things about those two causes of death. Part of the issue is there is very little what's called categorical funding that comes to us from the federal government or from the state historically for those two things. And as a result, departments of public health are just beginning to think about how and what to do about those two causes of death in particular. So what I'm going to spend some of my time talking about today is what we're doing about those causes of death, and one of them in particular, and I'll explain why. And then go on to a couple of other priorities to illustrate the breadth of things that are happening and have happened in the department. So what we looked at for the first time in Philadelphia a few years ago was the length of life, so life expectancy, for various racial, ethnic, and gender groups. And what jumped out, these are data from 2010, but what jumped out when we looked at the 2007 data was particularly the disparity in life between Asian women in Philadelphia and African American men. So both gender differences and racial ethnic differences. I will say that the difference has narrowed, particularly because of longer lengths of life for African American men based on statistics that we have, the death data, since 2007. And in fact, the life expectancy for an African American man is up by about 5 years in the last 5 years, and we're very proud of that. We have a long way to go. 19 years of disparity in life between those two groups is pretty outrageous. I'll also say that in looking at that, the general response across the country has been that health departments need to figure out how to address violence. The primary disparate killer is what everyone says between African American men and everybody else. And indeed, everyone here hopefully knows that violence and its disproportionate toll on African American men, African Americans in general, and people of color particularly, is really an outrage. I also have to say, though, that buried in this is the disparity in death from the two main causes of death, which have been overlooked. So we in Philadelphia have substantial disparity in death for African American men, African American women, Latinos, around cancer deaths and cardiovascular death. And the department decided to take on that set of issues about 3 years ago with increased vigor. And I have to say that it's been a really wonderful, sometimes frightening journey, in part because informing the public of the impact of cardiovascular disease and the risk factors for cardiovascular disease and cancer, informing the public about the impacts of those on disparity, has been at times a very difficult set of conversations. So, 3 public health priorities I'm going to talk about quickly today. One will be heart disease and cancer, 2 will be reproductive health for youth, and the 3rd will be how to make the beginning of life healthier for kids in Philadelphia. So again, cardiovascular and cancer deaths account for more than half of all deaths in the city of Philadelphia, matches fairly well to national data. What we knew in Philadelphia was that the rate of heart condition as something that people knew of seemed to be increasing from about 2004 on. And we knew that the rate of hypertension seemed to be increasing to the point where somewhere around high 30-some% of people in Philadelphia had hypertension. Data from the Medicaid program in Philadelphia suggests that almost 50% of adults on the Medicaid program in Philadelphia have hypertension. And we know that there are disparate rates of hypertension across racial, ethnic, and gender groups. The good news is that cancer mortality has been falling in Philadelphia as across the country. We still have disparity in cancer deaths, but at least the rate of death has been coming down, largely due to earlier recognition and better treatment. But unfortunately, the last time the federal government looked at city rates of specific types of cancers and cancer death across large urban areas was 2004, almost 10 years ago, and those data showed that the city with the highest rates of cancer mortality was Philadelphia. We had the second highest rates of lung cancer and the second highest rates of breast cancer mortality. The rates of both have been coming down, but we have no new comparative data to show where we stand compared to the other large cities in the country. Of course, a major reason for both cardiovascular and cancer deaths is cigarette smoking. This is data through 2008, where you see Philadelphia's rate of adult smoking had been increasing consistently to the point where we had almost 30% of adults smoking in Philadelphia, with the national goal of about 12%. Part of the reason for that is that in Philadelphia, compared to other cities, we have a lot of poverty, but our high rates are really extraordinary compared to the other large cities in the country, and our poverty rate is extraordinary. You can see the difference. These are the 10 largest cities in the country, and you see that extra large amount of poverty here in Philadelphia. It's been increasing during the recession, but poverty is related to cigarette smoking, poverty is related to mortality, and poverty, because it's not equally distributed in populations, as we all know, is a risk factor for disparity in terms of death. However, many people think that acknowledging the problem is sufficient. It isn't sufficient for a health department, and hopefully I can let you know a little bit more about what we've been doing. In addition, obesity rates, as you know, across the country have been going up. This is adult obesity. If we look across the country at large cities, Philadelphia County is the county of the large cities. Remember, many of the cities aren't counties themselves, so we have to look at their counties. Philadelphia is the county of a large city that has the highest rate of obesity as of 2010, and the highest rate, therefore, of diabetes, where, according to the Behavioral Risk Factor Surveillance Survey done by the federal government, about 12% of adults have diabetes, which is extraordinary. I have to say, in the very dark ages, when I was a medical student, 12% of adults having diabetes would have been considered something that was impossible in a population. This is the distribution of overweight and obesity in children in Philadelphia based on data from the School District of Philadelphia. These data didn't exist in collated form 3 years ago. So one of the things that we have done as part of the journey in the Department of Public Health is to improve our ability to generate data and understand how to use those data in terms of targeting, in terms of understanding phenomena. We still have a long way to go, as do I think all departments of public health. But you can see that obesity and overweight in children isn't evenly distributed across the city, and in areas where we have particularly high rates, about 1 in 4 children are overweight or obese. What was fascinating was to begin to look at data that existed within the department's hands but had never been used to try to gain insight into the obesity epidemic. So these are data that are on birth certificates throughout the Commonwealth of Pennsylvania and actually in many states across the country. And what you can see by weight quartile is the rate of cesarean section over years. So you can see that for women who are obese, the rate of cesarean section approached 40%. These data are through 2008. I can tell you that in the 2010 data, we're up to about 42%. So these rates continue to go up. It is extraordinary to see that, but Philadelphia's rates of cesarean section overall are lower than other cities and lower than the national average and lower than the surrounding counties. So the good news is, although this is terrible, and rates of cesarean section in the 40 to 50% range are just unfathomable, Philadelphia isn't worse than its surrounding cities. What I will tell you locally is, at Hahnemann Hospital, 2.5 years ago, all of the delivery tables had to be changed because 1 in 10 of the women coming in to deliver weighed more than 350 pounds, and the weight limit for the tables was 350 pounds. So, with that, adult diabetes rates have been going up. You notice that in Griffiths from 2010, the rate that they got in a smaller sample than the one from Public Health Management Corporation here in Philadelphia was about 12%, but look at 2012 with a rate of 16%. Really, I think, unconscionable rates. And as you know, diabetes has many other forms of morbidity associated with it, and lifelong challenges as well as expenses to the healthcare system. So that's part of it. There are lots of explainers here in terms of heart disease and cancer. One of them has to do with physical activity. So we can talk a lot about food, and I will, but I want to make sure I mention physical activity because it's often understated. These are data from the Centers for Disease Control Youth Risk Behavior Surveillance Study from high school kids in Philadelphia. So these are kids in 9th to 12th grade. And what you see by racial and ethnic group is the proportion of kids who report having used a computer for 3 or more hours per day, not for schoolwork. And if you're using a computer for 3 or 4 or more hours a day, not for schoolwork, you're also doing schoolwork for part of that time, and you're certainly not exercising very much unless you're tapping your foot or your finger. And this is watching 3 hours or more of television per day. While there's some overlap you could make them almost additive, so that if you think about it, probably 9 in 10 Philadelphia kids are spending at least 3 hours at a tube a day, which a generation ago was not the case, and 2 generations ago was absolutely not the case. So we have problems in terms of physical activity in our kids. One of the things I have to say is that that problem obviously correlates with things like violence and correlates with bad infrastructure and correlates with other things. And one of the challenges to the city as we took this on was to figure out what are the things that are changeable. And I have to say, one of the issues that probably the least amount of good insight has come to is what one does about screen time in modern America. So we've done a lot, and you'll see a whole bunch of things that we have done to try to encourage physical activity, and we're making some progress. However, screen time is an inexorable, continuing, probably in some sense necessary issue for modern America, and no one, I believe, has figured out how to address it in a way that really improves the public health of kids. We also have infrastructure issues beyond that, so public planning and how we build things doesn't always encourage walking within the city or running within the city, and sends out bad messages. We have advertising issues. Which of these would you rather think about and look at? Look at her and look at her. So we don't have a whole lot of money to spend in the public sector on targeting campaigns, so that in general we're pretty lame in what we do. Over the last few years, we've been able to amass a certain amount of resource to use top-end firms with top-end placements to take on media around some of the issues that we're going to talk about. And I have to say, public health, when it has the resources, can do quite a good job in competing head-to-head with this sort of advertising. And the other thing that we can't do a whole lot about is the relative cost on a national level of carbonated beverages versus other foodstuffs. And if you don't know, the federal government subsidizes carbonated beverages because of the corn subsidies that go on nationally. So we each are the taxpayers who are supporting people getting fat on carbonated beverages, whereas the relative price of fresh fruits and vegetables has priced them out of the hands and pocketbooks of many people who are poor in America. While we have subsidies that can help people, generally those subsidies are general food subsidies, and your food dollar doesn't go as far if you want to buy fresh fruits and vegetables. So one of the challenges to public health has been, what can we do to price these back into people's pocketbooks? And even if we can price them in, how do we make them available to folks? So beginning in 2010, the city was funded with large dollars from the federal government to try to figure out what to do about the issues of obesity and smoking and their then consequent issues related to cancer and cardiovascular disease. And in Get Healthy Philly, we were challenged by the Centers for Disease Control not to do what public health departments had traditionally done, which is things up here. Counseling and education. How can we talk to people about why it's not good to be obese, and how can we talk to people about why it's not good to smoke? What we know is, this is the health impact pyramid that was developed by Tom Frieden, who is now the head of the Centers for Disease Control. If we want large impacts on populations, we have to think about the things that have large impacts on populations. So the biggest predictors of bad health are socioeconomic factors and the environment or context in which you live. Government can do some things about socioeconomic factors. Government has much more ability to do something about context. The government in Philadelphia, and indeed the government in many of America's other cities, hadn't thought broadly about context and the contextual factors within its purview that could be changed and make it less likely that people would smoke or people would have issues around poor physical activity and eating unhealthy foods. So one of the challenges that we took on in 2010 was to do a broad, across-government look at what could be done about the contexts in Philadelphia and how government could influence them, with the hypothesis that if government did something here, we might actually make an impact on smoking or obesity. So with that, Get Healthy Philly has used a broad approach, looking at a number of contexts. So looking at media, looking at educational institutions, since we're a city with huge numbers of educational institutions and the largest employers overall are educational institutions. looking at the retail environment in restaurants, legislation and regulation, what's called the built environment, workplaces, how insurers and healthcare providers can do the right things, and so forth. Let me give you some examples. So the department had the ability to work with the State Department of Transportation to wrestle data from them on where pedestrian and bicycle accidents occurred in the city and to begin to map them. Once we could map them, we could say, here are places where people should be riding bicycles safely, but don't. Here are places where we have major corridors going across the city of Philadelphia, major streets, that people are afraid to ride their bike on because they know there are lots of visible accidents. What can we do about that? The Department of Public Health doesn't have the resources, ability, know how to do much about that, but the police department does. So the police department in Philadelphia partnered with public health on a campaign to arrest and ticket, educate, and provide all kinds of incentives to people. And the streets department got in gear and said, what can we do to promote biking and walking, like bike lanes and designated lanes in Philadelphia? And with that, we have 25 miles of new bike lanes in the city of Philadelphia. Hopefully everybody here is biking with a helmet. We have 350 bicycle wayfinding signs, that is signs all over the city, particularly near parks, that point people who are on a bicycle to safe places to bike, because we can put the lanes there, but if we don't tell people where they are, not always helpful. We have more than 43,000 second and fifth graders who had face-to-face education about how to safely be a pedestrian and how to safely bike. These are evidence-based interventions that go on in classrooms once a year that have lasting impacts on pedestrian injury and bicycle injury for kids. And a 39-week education and enforcement campaign that I mentioned throughout the city. The built environment is a huge area where public health is not always well represented. We trained everyone who is part of the city planning department in the city in what's called health impact assessment. So every time they had a question about how to move forward on city plans, they would think about the impacts of what they were doing on health. So they came up with all kinds of ideas after training, such as density bonuses, so that the square footage in a new store that wants to move into Philadelphia, if that square footage has to do with fresh produce, it's not counted in a square foot limit on a piece of property. So you can have a bigger space if you sell fresh produce. You can get more money from your retail because of that. Secure bike parking, you can see the others. The one thing that I particularly like is this one. So in the zoning code now, if you put in 5 bicycle parking spaces, you don't have to put in as many automobile spaces. If you put in 15 bike places, you can cut down on your automobile parking. It's a big deal in terms of space for new retail that wants to come in the city. And we mapped, for instance, tobacco retailers. So we looked at where all of the retailers were in Philadelphia, hadn't been done before, and we mapped them to schools. So what you have here is a map that shows the proximity of tobacco retailers to schools. 75% of all tobacco sold in Philadelphia is sold within 2 blocks of a school. That is not the same as in other cities, and we compared ourselves. And in fact, compared to other cities, we have the second highest per capita number of tobacco outlets of any other city in the country. Washington, D.C. is the only place that has a higher number per capita. So we got a lot of tobacco retail. We have a lot of smokers. And the department has done a lot to try to figure out how to regulate that retail environment, particularly because the state generally preempts us from doing very much about tobacco. But we have taken substantial steps to change that. I'll talk a little bit about it in a minute. In addition, in terms of the built environment, the city owns lots of property. Much of that property is smoke-free, but much of it wasn't. So for recreation centers, by a single stroke of the pen, the mayor made all recreation centers and all their property smoke-free, so that children working out in those areas, playing, doing homework, whatever, would not be exposed to secondhand smoke, nor would they be exposed to the idea that adults were smoking. And for the workforce in the city who works in those places, they had to go off-site in order to smoke. We gave them, as you'll see, a lot of support for that. We didn't want people to have something taken away without getting supports to help them. So we now have about 850 new smoke-free acres in the city of Philadelphia. We're now considering what to do about parkland, and there will be soon new action about smoke-free parkland in Philadelphia. 170 of the schools in Philadelphia created wellness councils that were initially led by the principals, but included principals, teachers, the office staff, parents, and kids, to try to figure out what the school could do to be healthier. Sometimes that included going to the corner store across the street and asking them not to sell tobacco. But within school, it had to do with how do we limit unhealthy things that are going on in the school, particularly unhealthy uses of foods within the school, such as giving classroom awards of candy, selling soft drinks in school stores, and so forth. In after-school settings, the city funds an enormous number of after-school programs. Those after-school programs now have better meals, so we are feeding upwards of 3,500 kids every day a full supper that is nutritionally complete and is desirable to the kids. Before that, we were offering about 1,200 kids snacks in the afternoon that included two not necessarily nutritionally very good things, and 85% to 90% of all that we were giving was thrown away. The wastage rate now is down to less than 10%, so kids are actually getting dinner in poor neighborhoods through the city without a dollar of city funds being used. These are all federal dollars that we're able to draw down. And I see Mariana Chilton here, who is one of the people who has helped us and spurred us on to do this. And in addition, not only are we doing food better in recreation centers, but we're doing physical activity, in after-school programs, but we're doing physical activity. So in our 94 recreation center after-school programs, believe it or not, there was no physical activity. We've now taught the people who run after-school programs in recreation centers how to do recreation with kids, which they hadn't done in years. We are trying to prevent tobacco sale to youth. I talked about the density of tobacco retailers. Well, we've increased the penalties for those who sell to youth because it's illegal. We have 2,700 tobacco merchants who we've now educated about youth sales prevention. We have a new permitting system in the city, which is not preempted by the state, which allows us to, for anybody who wants to sell tobacco in Philadelphia, assure that they behave well. You don't behave well, we pull your permit. Your permit doesn't have anything to do with your state license for tobacco, but it says you can't be a business that sells tobacco to children in Philadelphia. We're going to stop you from being a business. We're not stopping you from selling tobacco exactly. We're stopping you from selling anything if you sell repeatedly to children. The city is allowed to do that. It has to do with business, not specifically tobacco, but we're using breaking the law about tobacco as one of the reasons why we can pull your business license. And we have a number where the public can report if they think the law is being broken by retailers. And we get those reports and we go out and we then inspect and we take that forward to court if we need to. Illegal tobacco sales to minors in Philadelphia have decreased 20% through this effort. We have 10 new farmers markets in low-income communities in Philadelphia that are self-sustaining. They're located generally at transportation hubs, but they're bringing fresh food to neighborhoods. We used a program of the Food Trust, which is based here in Philadelphia, we call it Philly Food Bucks, which is supplementing food stamp dollars with additional dollars to provide an incentive. If you buy fresh produce at a farmer's market, you get $2 extra to use at that farmer's market for more produce. And with that, we've increased food stamp or SNAP redemption at farmers markets by more than 300%. The food buck users were twice as likely to increase food and vegetable consumption and try new fruits and vegetables as people who didn't use food bucks. It's a mouthful. But the biggest source of food in communities is corner stores, which have been wastelands for bad food and bad nutrition in Philadelphia. One of the things that we have done is to work now with 650 corner stores to get them to offer some degree of fresh produce. And we have now more than 150 corner stores in Philadelphia that have gotten either shelving or refrigeration to make them into mini fresh food markets. On average, mini conversion stores have now introduced at least 20 new products, and the mini conversion stores have particularly increased low-fat milk and fresh fruit availability in neighborhoods that I can assure you haven't had it before. Here's the distribution of corner stores. If you know poverty in Philadelphia, you'll recognize this area and this area and this area. So the healthy corner stores were particularly targeted for neighborhoods where people are very poor. And what we're able to do that I love a lot is, with a lot of fancy GIS work, we've been able to map every house in Philadelphia and to see whether or not within a 10-minute walk, people who live in that house can get their hands on fresh produce. So this is in 2010. Pink is the homes where people had to go more than 10 minutes by foot to get their hands on fresh produce. And this is 2012. Green represents the areas that now have access to fresh produce within a 10-minute walk from home. So we have a measure of, and we can add up all of that and integrate it under the curve, and we can show the significant difference in neighborhoods throughout the city in terms of access to fresh food and produce. In addition, we have lots of workplaces that are pretty unhealthy in Philadelphia, and lots of people from neighborhoods where people have not had a lot of good access to healthier food or education about healthier food work in a lot of places in Philadelphia. One of them is the city of Philadelphia, where we have about 23,000 employees, 25,000 employees according to this. We've lost a few since this, since the original estimate. But we have in the city about 220 vending machines. The vending machines sell all kinds of crap, as they do throughout the world. And we have worked with the city procurement office and now the vendor who supplies us with those machines to have smaller sizes of anything that has sugar, to have a healthier mix so that now more of the buttons on the machines actually relate to water or diet soda, to have calorie labeling on the machine so people know how many calories they're getting when they push the button, and to have healthier marketing. That is the decal on the machine. See, I know the word decal, which I never knew it was called a decal before 2010, but the decal now is water and not Coke. We have nearly 100 machines with healthier snacks as well, so if you'd like healthier snacks or soda, come on to city government. We will, I can tell you that the first place we did everything was on the floor of City Hall where City Council is located, because that's two things. One, they know we're doing something, and they hate it. And two, it's where the greatest number of people come on a daily basis. So we wanted the public to see what's healthier. And we wanted not that everybody who comes to City Hall uses these machines, but at least they see them. We want to begin to move people to think that things can be healthier, that everything doesn't have to be unhealthy, that the machines themselves aren't necessarily bad, it's what's in the machines that are a problem. The Hospital of the University of Pennsylvania, with 31,000 employees, has now implemented our healthy beverage vending standards. You can see the other employees. I will mention in this room that there's a certain large university and its hospitals in Philadelphia that aren't on this list. I'm not going to say any more. Insurers, in terms of tobacco in particular, we are doing a lot to make it harder for people to smoke. We have a lot of smokers in Philadelphia. We know that you are twice as likely to quit smoking successfully if you quit with help. Help is both medication and counseling. For many people in Philadelphia, medication and counseling is too big an expense. So, one of the things we've done is to begin working with insurers and employers. We now have a business working group and an insurer working group to get people to change what's covered under insurance so that people can better afford smoking cessation help. And probably the group of people who had the most price sensitivity were people on the Medicaid program. Pennsylvania allows the Medicaid program to charge co-pays to adults and to have what's called prior authorization. So if you want to get nicotine patches, you have to have your doctor call the managed care company, and the managed care company has to sit 5 days, and then they can approve it or deny it, and then they have to call your doctor back, and then your doctor has to find you and get you a prescription, and then no more. Co-pays are gone, and prior authorization is gone for the Medicaid recipients who are adults in the city of Philadelphia, and kids actually. So we have about 100,000 low-income people in Philadelphia. About half of those adults smoke, who now have access to smoking cessation medication. And we've seen nearly a 10-fold increase in the state quit line, which we're now funding, and we're providing nicotine-free through the quit line to people who call from Philadelphia. Media. So we were able, as I mentioned, to hire a major media firm and use them to design a media campaign with the greatest technologies that are out there for sampling people and figuring it out and doing focus groups and all that good stuff. So there are two campaigns that I'll highlight. One is the tobacco campaign, Quit with Help, Quit for Good. Hopefully everybody here has seen one of the ads somewhere. You may not recognize that you've seen it, but probably that little box, if you have one on your TV, lets us know that you have. In addition, on buses and trains and all kinds of things, the radio has been a big source in order to motivate smokers to quit with assistance. Why try quitting if you don't have assistance? Assistance is easy. Here's assistance. Quit with help. We have about 50 million impressions, which is people who have seen an ad at some time. This is one of our more successful ads. You can imagine who it's targeting. It works quite well. We've got really nice evaluation data, if anyone would like to see, that shows just how successful it is and how it hits the demographic that we want in particular. And for media, we have gone after sugary beverages. If you couldn't guess that from my presentation, you should know. We are really after sugary beverages. They are they're the cause of excess calories in the American diet, particularly for children and the poor in America, that nobody needs to be ingesting. They are marketed heavily. There is no successful government action thus far in America that has made a difference on this, because the beverage industry is spending billions of dollars counteracting public action. And we decided that raising awareness was incredibly important because we lost twice trying to tax sugary beverages in Philadelphia, and we realized the public needs to move along with us. So we have really been trying to bring the public along, that was quick, with media campaigns. I will say the most effective campaign is a radio campaign between two young women who are talking about the connection between sugary beverages and diabetes and children. Incredibly impactful. We have really nice evaluation data. Legislation and regulation is the province of government. There are a number of laws that have passed, bunches of regulation that has been looked at across a number of agencies in government. The menu labeling law, hopefully everyone here knows that Philadelphia has the broadest menu labeling law in the country. It was implemented on January 1, 2010. It includes menu labeling at chain restaurants with at least 15 stores for sodium, calories, saturated fat, trans fat, and carbohydrates. It was preempted by the Affordable Care Act on March the 23rd, 2010. We've still gone forward. We're not enforcing, we're educating. The minute we enforce, until the federal government puts out final rules on menu labeling, which currently preempt us, as soon as we enforce, we'll be taken into court by anyone with whom we try to set a penalty. So we've tried to do it the easy way. Mimi Auchincloss, who is from the school, who is where? There you are. Hello. Has been a partner in evaluation on this, and we are very pleased with the early evaluation data. We have a very long way to go to educate the public. So while we have labels in restaurants, we need to educate the public a whole lot more about what the labels mean, which we're thinking of how to do, and we need to begin enforcement, and that's awaiting the federal government's final rules and then action on a request that we have to be exempted from preemption. And these are all of the Get Healthy Philly sites in the city of Philadelphia. So we have blanketed the city. We have particularly blanketed areas where we have folks who are of lower income, which are also the areas that you may remember where we had high rates of obesity and smoking. And we are hopeful that we will continue to see progress in this area. The other piece of this is the public sector's infrastructure to have data that informs policy and what we can do around causes of cardiovascular disease and cancer. And for this, we have a small grant from the federal government to develop infrastructure on monitoring systems. So we're partnered with folks here. I see Wang Jing back there, who's a partner with us on this, to figure out how to collect data on hypertension. Not easy, I can tell you. How to collect data on adult immunization and cancer screening, and then work with healthcare partners on policy changes within institutions, across institutions, by insurers, and by government. And finally, provide the public with better information on the quality of services. That is, how's everybody doing on hypertension care? How's everybody doing on adult immunization and so forth? You may be able to see this line here. These are data that each point represents a zip code in Philadelphia. On the x-axis, you have the poverty rate. On the y-axis, you have age-adjusted mortality rates. And these are age-adjusted mortality rates from cardiovascular disease. And what you see is a real scatter. You see that there are some zip codes that are very poor and above the line, and some zip codes that are poor and below the line. Above the line means excess mortality from cardiovascular disease. Below the line means less mortality than expected from cardiovascular disease. We're now using this to target zip codes, where we're doing a fairly deep dive to look at what are the infrastructure issues. Are there pharmacies? What's the insurance coverage? What goes on with parks and recreation? Some attitude sampling and so forth to try to understand what are the local factors that impact cardiovascular disease death. Another area is, as I mentioned, partnerships. I just want to make sure everybody here knows that on May the 3rd, we will have a Kidney Action Day where we will do massive blood pressure screening just out here on the Municipal Service Building Plaza. The American Kidney Foundation is partnering with us and all of the academic health centers, including Drexel's medical school. And everybody here should come and get your blood pressure checked. If you'd like to volunteer, we can hook you up with the kidney folks who are doing this. We're going to highlight for Philadelphians the connection between kidney disease and hypertension. But we've made a lot of progress. This is the progress before 2010. So schools in Philadelphia began nutrition education for all SNAP-eligible children in 1999. Very cutting edge at the time. In 2004, comprehensive school nutrition policy was passed, not well implemented until we put in place wellness councils, but passed. The trans fat ban in Philadelphia passed in 2007, menu labeling in 2008, and was implemented in 2010. The Complete Streets Executive Order was passed. That said that whenever we were changing a commercial corridor in Philadelphia, the streets department and the planning department had to think about that street as a place not just for cars, but for people as well, and what we could do to increase pedestrian and bicycle traffic on those streets. The school district put 1% milk in all of its school cafeterias instead of higher fat milk, and took out the fryers in 2010, and finally Get Healthy Philly started in 2009, and Get Healthy Philly started in 2010. So the question is, does anything make a difference? You're all public health folks. I'm a public health person. So what? I told you all kinds of stuff. So what? Well, this is what happened from up until 2010. Between 2006 and 2010, when we all heard in the media that obesity was continuing to increase in children in America, children in Philadelphia were getting thinner. All of those changes, and probably other things, made a difference. We saw in that 4-year period the greatest decline in childhood obesity of any city that's reported to date. And we are the only city where those declines go across racial and ethnic groups besides white children. And to sort of give it to you simply, there it is with the timeline. So lots happened here. That made a difference. Lest anybody say that policies within government, in particular schools, can't affect children's health. They certainly can. And I will say that if we look at women's health, this is where Get Healthy Philly started. And what we see is that with Get Healthy Philly, we start to see a decline in maternal pre-pregnancy obesity. And here we see, for the first time, these data are not yet reported, so they're hot off the press, but the first city in America to report a reduction in adult obesity across the group of adults throughout the city. And the reductions go across racial and ethnic groups. They're small but significant. So we're really pretty proud of what's been able to be achieved in Philadelphia. This is smoking. So the city with the highest smoking rates in America is still the city with the highest of the Big Ten smoking rates, but we've turned around the curve. So we've gone from a city with increasing smoking rates to a 15% reduction in smoking among adults in Philadelphia over that time. Unfortunately, diabetes, as I showed you earlier, continues up. Remember that diabetes is a disease that reflects long-term exposure of vasculature and the pancreas to obesity. If we reduce obesity rates in adults for a decade, we should see a change in this curve. But the long-term impacts of the obesity epidemic are going to be with us for a very long period of time, and the same goes for hypertension. So we're now looking at what specifically can be done to begin to change what goes on in terms of outcomes for people with diabetes and hypertension in the city. Okay, there's one. Two, and I'll go quickly. Reproductive health for youth. I have to mention it. It is a terrifying thing in Philadelphia. Anybody here who works with young people should know that we have a real crisis in terms of reproductive health. While HIV only accounts for about 1% of deaths, reproductive health is almost an oxymoron in the city. HIV rates have been coming down. It's a good thing because largely of treatment, or excuse me, AIDS rates have been coming down because of treatment. This is the date by diagnosis of AIDS and HIV. You can see the impact of treatment on AIDS deaths, AIDS cases and AIDS deaths, and here you see HIV. However, this is from the Youth Risk Behavior Surveillance Survey. Again, high school students in Philadelphia. These are the cities that are reported by the Centers for Disease Control. And what you see is Philadelphia has the second highest rate of ever having had sexual intercourse among 9th to 12th graders, and we actually have the highest rate of having first intercourse before age 13 of any city reported by the Centers for Disease Control. In terms of being currently active, sexually active, highest rates in the country and the highest rates reported of those kids who report 4 or more lifetime partners. And when it comes to forced sex, I have to tell you, this is the 2011 data. In 2009, Philadelphia had the highest rates reported. That was because Chicago and Detroit weren't included in the sample reported in 2009. So we don't stand on our laurels here. The rates are incredibly high and too high in terms of 15% of girls reporting dating violence and more than 10% reporting having been forced to have sex. And this is 9th to 12th graders. So these are fairly young kids still. 1 in 8 Philadelphia girls aged 15 to 19 years of age had gonorrhea or chlamydia in 2010. 1 in 3, based on those data, have had one of those 2 infections at some point during their teen years. Gonorrhea showed a 52% increase in adolescent case counts between 2009 and 2011, and 25% of new HIV cases are in those who are in their adult and young, adolescent and young adult years. 75% of them are sexually transmitted. So if you were the health commissioner, you might not sleep well at night, particularly if in your background you had done adolescent medicine. So if you want a kick in the pants, let me tell you, this was a kick in the pants. In 2010, we assembled the data on reproductive health for teens. It had not been assembled in this way before. And we all sat down and said, what are we going to do about this? And we looked around the country. Other places in the country saw us, not quite as big, but saw increases in sexually transmitted infections during the 2009 to 2011 period. And cities responded in different ways. Many of them did nothing. A couple of them did some interesting things, which we've tried to model and expand. One of the things that was interesting to us was, despite the fact that we were on this end of the curve for everything else, we were on this end of the curve for condom use. So we thought we had some ability to make a difference, at least to bad outcomes. We might not make a difference to rates of sexual activity, but we might make a difference to rates of safer sexual activity and raise the profile of reproductive health if at least we targeted the environment in Philadelphia for kids around condoms. In addition, we felt like broad education for young people about reproductive health was an important thing to do, and we thought that the way that we test partners, particularly young partners, could be improved. So we have tested a partner for an individual who has an STD. What we know from better research that's been done more recently is that generally kids have a network of people. And they may have sex with John, but John's best friend George may be tomorrow's best buddy, and the next day it may be somebody else, all of whom are in a social network. So when doing partner tracing, one of the things that we're now doing is asking about friends within a social network. And we're doing education of social networks, particularly piloting this in West Philadelphia, where we have the highest rates of STDs among youth in the city. We kicked off the first Philadelphia condom contest. Go on our website to learn more about it. We made condoms more available in more locations. We now have condom dispensers in 12 of our public schools, and when kids come back to school next September, they'll be in all of the public schools, high schools. We're using alternative media extensively. We are a really nagging and annoying presence on Facebook for kids in Philadelphia. If you're a 15-year-old girl and you're on Facebook, flashed on your screen is, if you're sexually active, go to our condom site and learn about the Philadelphia Department of Public Health. They hate us, but they go. The number of hits to our website has gone up, and we now send condoms through the mail to kids who sign up for them on our website. So we are giving out hundreds of thousands of condoms through the mail to kids in Philadelphia. We gave out in the first 3 months 37,000 condoms through dispensers in schools, and through our face-to-face programs where we go to every school and teach about sexual health, we gave out another 47,000. So we're up, reaching another 100,000 that we'll get through school context. So we're hoping to blanket kids, pardon the expression, in Philadelphia with condoms. What we know is that schools are an incredibly important place to affect reproductive health. The city instituted testing once a year in high schools throughout Philadelphia, beginning here, as you can see, here in 2002, and what we saw, here in 2000, and what you see is from that time forward, we decreased the rates of PID cases, pelvic inflammatory disease cases in women. It's the only successful intervention proven to reduce the incidence of pelvic inflammatory disease in young women to date. So chlamydia cases are down 5% in 2012, first time in 4 years they're down. Gonorrhea cases, which had a 52% increase, are down 6%. As I mentioned, we've given out lots of condoms. In fact, 4 million condoms have been given out since the initiation of the campaign. My last thing I'll go through very quickly is a healthy start to life. We know that this is the curve from a meta-analysis that shows the return on investment if you invest $1 in an intervention by the age of a kid. So here's the curve that shows the return on investment. This is $1, $1. So if I invest $1, the public sector will get that dollar back if I invest up till age 7. After age 7, they're continuing. It's better to invest earlier than late, but the return on investment to the public sector is best if we invest in young children. The department's resources disproportionately, and across the city, the 4 departments that were mentioned that I run, our resources disproportionately go to youth because they're the ones who do the bad things. We've been trying to move some of those resources to do better things for kids. So we've instituted something in North Philadelphia in the police district with the highest rates of violence, the highest rates of crime, the highest rates of abuse and neglect of children, called the MOM program, which is a program to help parents assure that their children are ready to learn. Because if a kid is ready to learn at age 5, that kid will read at age 7, and if a kid reads at age 7, that kid is significantly much more likely to graduate. That's the point of inflection where that curve crosses. We want every kid to read by the time they're in 2nd grade so they can read in 3rd grade. It's universal. It involves home visiting and phone follow-up for kids before pediatric well child visits. We use a lot of phone, although phones go off and on and off and on. And we're consistent with folks, and this is universal from birth to age 5. We enrolled our first 1,000 kids. This is the pilot data that was done for this program, which shows that early intervention referrals were improved almost significantly. Early Head Start, very significantly. Daycare went down, but Head Start, that is educationally enriched daycare use, went up highly significantly. And in terms of the future of Philadelphia, physical aggression use by 5-year-olds was reduced significantly. I'll mention that injury to parents went down, not statistically significantly, but when we did a little bit of ethnography, the principal kind of injury that went down in mothers was domestic violence. So it's inexpensive on a per kid basis. It's linked directly to hospital discharge. Based on the data that we have on Universal Head Start, so if we get all these kids in Head Start, we'll have great lifelong impact, and it creates jobs in low-income communities for home visitors and people on the phone. We've implemented in 3 zip codes in North Philly so far. Hahnemann Hospital is one of the enrollment sites. We have workers who are from the community, based in the community, and it's a fully bilingual force. We've said we'll do a pilot through case 1,000 and then expand from there. We're about to hit our 1,000th case, so we're thinking about how to expand into more zip codes and more hospitals in North Philadelphia. Those are our websites. I'm happy to take questions.
Please use the microphone because we're recording this, so.
Uh-oh.
Hi. I have a question about your mom program.
Yeah.
What goes
I
on
sort of
in
went
those
through quickly. Yeah.
in those home visits?
Yeah. What goes on?
Yeah.
So the model for the mom program is to help mothers understand how to access educational services for their kids. How to go to primary care and ask about child development, how to incorporate that child development information, how to get kids assessed for early intervention if they have a developmental need, how to get them into early intervention, how to get them into enriched child care experiences, how to get them into Head Start, and how to get them into kindergarten.
Hi.
Hello.
Given the trickling down effects of the sequester, the end of general assistance, and the reluctance in the governor's mansion to expand state Medicaid programs under
You
the
are a
ACA.
really half-empty guy, aren't you?
Kinda. But, I mean, Philadelphia leads the nation in deep poverty.
We do.
What is the health department doing to lessen the impact of these budget cuts, and what should we all be doing?
Okay. So probably the most important thing that we're doing is we run 8 federally qualified health centers where we see everybody. And a little known fact is the health department actually has a health plan of sorts. So if you come to us and you're uninsured and you need specialty care, we'll get you to the specialist. If you need complex diagnostic care, we get you to diagnostic care and we pay for it. We have contracts with the large health centers in town to get people there, and it's regionally done. So for where the health center is, we have arrangements with each of the hospitals that are large hospitals in those areas. So we believe our role is to assure that people who are outside of any safety net for health insurance get care. About 52% of our patients are uninsured and uninsurable at the moment. The bigger question is, what are we doing to get the governor to do the right thing? And all I can tell you is we're doing a lot. The mayor is very active on this front, and he is part of a coordinated initiative with HHS to see what we can do in Pennsylvania. That's all I'm at liberty to say, but I am very optimistic that we will ultimately expand Medicaid in Pennsylvania. I don't know if I'll be right, but I'm hopeful. Yes. Yep.
Oh, I have a question while we're on the topic of poverty. You didn't really cover it in your section on reproductive health, but certainly an issue in Philly, as you know, the Gosnell trial has been happening this week.
Yeah, I'm well aware.
Is access to safe legal abortion care for women who need that service. And I know you've been really commendable I read the grand jury report that came out of it, and you actually took accountability, which was great leadership. So thank you for that. But the ambulatory surgical facilities law that was passed in Pennsylvania, can you just talk about that a little bit? And that's actually, I guess a lot of people are afraid that's actually hindering access instead of helping access.
I think that's a very appropriate concern. I'm concerned about that. I've been concerned since the time of the grand jury. The suggestion that the ambulatory surgery rules should extend to abortion facilities came out of that grand jury report. It didn't come out of my mouth. And I think it was inadvertent. I think they were trying to do the right thing. Once that got out to the Republican committees in Harrisburg, it was over. And despite a fight, so it was defeated. You may know the first time it was put up, it didn't get out of committee. The second time it was proposed, it got out of committee and missed on the floor. They actually, they let it expire. And the third time was when it got passed. So we're very worried about it. I talked to the providers of care in Philadelphia. We believe that any legally appropriate service should be accessible by all Philadelphians. And we try to be as supportive as we can. Mariana.
Dr. Schwarz, great to see
Dr.
you.
Chilton.
So glad you're here. I'm so impressed with what the city is doing. So thank you very much for your leadership. It's really tremendous, and what a great city to be doing, in which to be doing public health work. Thank you very much. And I'm also really impressed with, especially with your attention to forced sex, as you call it. I'm not sure what that really means. I'm not sure why we're not calling it rape. But
it has to
whatever.
do with the language that the Centers for Disease Control uses based on testing with kids about how they respond. They don't think of themselves as raped. They think of themselves as forced to have sexual activity, unwanted sexual activity.
Thank you very much. And I want to follow up on some of that outside of here. My question, official question, has to do with paid sick leave for the city. And just to bring everybody up to speed, City Council passed 11 to 4 or something. I don't really know. City
there are
Council.
17 council people, so I think it must have been 11 to 6.
11
I
to
don't
6,
know.
sorry. Thank you. There's my political knowledge going down the tubes. Anyway, the City Council passed a paid sick leave bill requiring businesses with a certain number of employees to provide paid sick leave for their workers. And just today, our mayor vetoed that. And I wanted to know if you could maybe talk about some of the potential struggles between public health and business, and because I can imagine that paid sick leave is really good for our workforce, not just the people who are actually sick and who need to take time off, but also the other people who are at these agencies and corporations. Not to mention, I'm so glad about the food menu labeling, but in the food industry, I know that the food industry, the restaurants have not been behind paid sick leave, and I was wondering if you could talk about it from a public health perspective and also as the health commissioner, what's going on.
So I'm going to give you an answer that you don't want to hear, which is I can't talk about it from the health commissioner point of view. I work for the mayor, and he put out his statement and made his decision. And I, as someone who works for him, have to support his decision. I can say that it's a complex set of issues, that on face, it looks simple. Folks should read the legislation and should talk to people on both sides of the issue. So there are two sides to every issue. There are two sides to this issue. While it's been portrayed as, do people support paid sick leave or not, there are a lot of different pieces of legislation that can be drafted to support paid sick leave, and the particular piece of legislation that was proposed is one that the mayor vetoed.
Dr. Schwarz,
Yes.
thank you very much for a wonderful talk. I have two epidemiology questions. I'll just ask them. Well, I'm sure you'll be okay. The first one is, given the issue of smoking, obesity, and hypertension in the city of Philadelphia, on your causes of death, I didn't see stroke listed.
So it's lumped into cardiovascular. It's the vascular piece. And I did that for simplicity. I use this for a lot of audiences, that particular slide. But vascular is a much smaller piece than cardio, if that's what you want to know.
Yes, but I mean, chances are it's number 3 or number 4 in terms of leading causes of death independently. So I just wanted to know, and it has a different clinical consequence than...
It does, although hypertension and obesity are both risks, as is smoking.
Yeah, and then the second
The
question
risk
is...
profile.
The second question is with gonorrhea. What's the experience in Philadelphia of some of the new drug-resistant gonorrheal strains that we're seeing?
So we have them. It depends on which strain you're talking about, super strain or somewhat super strain or not quite so super strain or somewhat resistant strain or not so resistant. Yes. The answer is yes, we have them, very few cases. And we're careful to jump on and isolate those cases. You may know that the largest tester for gonorrhea in the city of Philadelphia is the city of Philadelphia. So lots of hospitals test for gonorrhea. The biggest single source of testing is the city. And we do, and hospitals do, resistance testing. The problem is if people are identified with gonorrhea based on what are called nuclear probe tests, no one knows the resistance profile because no one has the organism. All they know is that the organism was in the body. So by having quick testing for gonorrhea, we don't have an easy way to know the occurrence, how many people in the city of Philadelphia actually have resistant strains. So we have, in the city, we do monitoring of the cases that come to us, and we use that to try to figure out what proportion of cases, it's still a very low proportion, have super resistant strains, but we're worried about that. Microphone, microphone. Uh-oh. Can I do this one and come back? Okay, yes, ma'am.
I love the idea about all of these smoke-free areas in Philly, and I was wondering what the city was thinking about in terms of enforcement.
Okay, it's a great question. So the experience across the country is that you don't do much better with enforcement compared to posting of signs. Because generally, if a sign is posted that says no smoking, we now have a sufficient number of rabid non-smokers that a smoker who disobeys the sign is usually an outlier and a pariah and usually censored in one way or another. So rather than investing a lot of dollars in enforcement, which we don't think would make any difference compared to what's going on, we do monitor. So we have people who go by and check in a period of time how we're doing. And we think that actually we're being pretty successful in getting rid of people smoking on grounds where they're not supposed to smoke.
Hi, I'm not public health trained, although I have a public health interest, particularly focused on violence. And I was a few minutes delayed getting in. I wondered if I missed that or if that's been omitted for a particular reason.
So I could only pick a few things. One of the things that I have to say is there's a lot going on in terms of violence prevention, not just in the city health department. There are lots of folks, including folks here at Drexel and Hahnemann, who are doing substantial amounts of work. When we looked across the city at what the role of the public health department should be in violence prevention, we felt that we could be advisors. We felt that we could help with data. But in Philadelphia, if you look at the rates of particularly homicide and gun-related violence, the best experience across the country says the first thing that has to happen is the police force has to get its act together. Our police force has gotten its act together. So in 191, the 22nd Police District, North Philly, just north of here, we had the highest rates of homicide, particularly all ages, but young people in particular. Those rates are down substantially in the last year because the police have changed policing patterns. That's been the case in New York, that's been the case in Washington, which are currently the two cities with the greatest impact on gun-related violence. So what I have said is let the police do their thing. The next step in that is what do we do long-term? And there's a lot of discussion. There's an active committee. John Rich from the School of Public Health is a member of the task force on this. And the city is trying to get its act together in terms of what it does. But my feeling has been that until the police do what the police need to do based on the experience in other cities, public health trying to do it alone only deflects the attention from the police. And I wasn't willing to do that. So the police have now gotten into gear, particularly in certain neighborhoods where they hadn't been so in gear. During the recession, one of the things that happened was the city stopped hiring new policemen. We're now hiring again. It's a really good thing. So our complement of police is going up. You're going to see, I think, the impact of that. At the same time, we have a very large number of policemen who are retiring. The police department is trying to figure out what to do about that. It's a terrific thing in the following way. Older policemen are much less likely to be on foot patrol. Younger police people, not just men, are much more likely to be in neighborhoods. So I think just the demographics of the police department over the next 4 years is likely to have an impact as well on community level safety. And then all the rest of us, the people from public health, the people from child welfare, the people from juvenile justice, the people from behavioral health, the people from the streets department, the people across the city and all of the partners need to go in and figure out what are the more basic infrastructural things that need to happen, like jobs and clean lots and better lighting and more people on the streets and easier transportation and so forth.
Looks like I get the last word.
There's one more. May I do
one more?
Oh,
behind me?
Okay. Mine? And then you can do the last word. I'm sorry. Yes, sir.
Thank you for a great presentation, Dr. Schwarz. I'm just curious, if we consider other similar target population groups, if you go to the west, to Norristown, to the east, to Camden or Trenton, how do we compare to those particular types of communities?
We don't know. And the reason is that data aren't generally gathered at the community level. They're gathered at the county level. And when we have data that are from the city, those data, particularly small cities, the data are pretty old. So even from big cities that are part of counties but aren't cities themselves, you can see the last time we have cancer data from municipalities, large municipalities in the country, is 2004. It has to be a special analysis. And in fact, we've tried to partner with communities to get census tract level or even zip code level data. It's very hard to do. So I don't know. I can tell you based on poverty rates what I think they'd look like for Norristown or Chester or Camden. And I think it would be horrifying to people, but I don't have the numbers. The last word.
I think. I don't know. All right. So first of all, I want to add my gratitude for an outstanding presentation, and I think more importantly for all the work that you've done and continue to do, and data that can show that there's an impact and a difference for all of the gazillions of dollars that have gone into these kinds of things over so many years for, so many of us working here. We've never been able to show the kinds of things that you're here showing us today, and it's a thrill. The question that the dean promises to get to. So I'm always happy when the faculty and students that were engaged in the region, like some of us in the audience, you have an illustrious career of academia, public health, applied practice, government, major government official. So on the advice to the academic public health world, I'd love to hear a minute or two, and I know there are people, especially the students, are on time schedules here, but what your thought is now that you're in the governmental side per se, and then you come to visit us in the academic side, filed under how we can help, right? Here we are, and we have a knowledge base, and what do we do when we hear this?
I love that question. Thank you. Two things I'll say. One is there's a whole lot of research that's necessary for people to get promoted, and I don't want to minimize that. So people getting promoted in academia is part of people's job and life trajectory. What I can tell you is that it is often hard to publish results that are useful to the public sector. And that is a fundamental, in many cases, conflict for academics who wish to help people in government or in the public sector. Doesn't mean you can't do good, but in the public sector, what is policy relevant, that is, what helps change what we do, is pretty discrete and pretty limited because it depends on what politically is doable, what's the political reality, and what we have resources to do. And often it's hard for folks in academia to hear that and respond to that. In addition, the timeline for government is a whole lot quicker than the timeline for academia. So if you're not fleet of foot, it's hard. Now, there are a substantial number of people here who have been incredible partners and done incredible work with and for the department over the last few years that I know of, and many who are here who have done it for a long time. So I want to acknowledge that. And that represents, I think, folks who are fortunate enough to have their career and their moment happen at the same time that government is having its moment in focus on an issue. So that is a big way. The other way is to inform us. So there are many people here who are terrific advocates who have informed us, me, others in government of really pressing problems. Raising issues, be it what's going on for people who can't get away when they're sick, or what's happening in terms of Medicaid and coverage in Philadelphia, or what's going on in terms of violence, or what's happening in other cities. Those are all important things to remind government about. And your job in part is not to be government, but to be a voice outside government that helps advocate for what's important. Sometimes government can respond to that, sometimes it can't, but boy, I value the voice of academia, making sure that we're honest and we're informed and we do what we need to do. I will just say that there was a time when I thought that voice came from the media, and being in government, I have at times been appalled to see that the media doesn't have that honest voice any longer. And that's a tremendous loss. So I think that raises the importance of academia as an advocate and voice for good, solid investigation and helping to raise issues that may not be on the radar screen otherwise.
Great. So thank you again, Dr. Schwarz, for coming by and for your service to the city of Philadelphia. I also want to thank the audience for attending today's Grand Rounds and invite all of you to come to our next Grand Rounds featuring Eric Gooseby, who's actually the United States Global AIDS Coordinator, who will discuss global health and human rights, the challenges of scaling up effective programs with partner countries. So please visit the schools. Oh, I'm sorry, April 18th. So that's also a Thursday. And you can also check out the school's online events for more information. So thank you again.
Thank you.